said. Patient gets lost in the midway. So either of the other three, one is disorganized thinking, another is altered level of consciousness. So you have to classify this alertness. One is you can label the patient being alert, which is normal. So levels of consciousness can be alert, it's normal. Patient can be hyper alert, we call it vigilant. Another is patient is drowsy but is arousable, that's called lethargic. Patient was lethargic, patient was drowsy but is arousable, so lethargic. Another is patient is in stupor, so patient is drowsy but is not able to, we are not, but it's difficult to arouse, that is stupor. Whereas unarousable is coma. So how you are going to identify this cognitive dysfunction? There are certain scales. One is modified blessed dementia rating scale. Modified blessed dementia rating scale. Another is clinical dementia rating scale, CDR. Modified blessed dementia rating scale. Another is clinical dementia. Both are DRCs. Both are DRS. One is modified blessed. Another is clinical. So medications are always a common cause of delirium, especially compounds with anticholinergic or sedative properties. 1/3 of dementia, approximately. So 1/3 of patients who are going into delirium, they have used some kind of medication. That's why they have gone into delirium. That's why whether they have used any over-the-counter or herbal medication, it should be screened. Also, important elements of history include to screen the patient for any organ failure or systemic infection, which is also often the contributing factor to delirium in the elderly. Note that both dehydration as well as fluid overload can lead to hypoxemia. So patients who have hypoxemia, either they are having increased fluid or decreased fluid, so they need to be assessed, which has also been associated with delirium. So patients who often worsen in the evening, that is they who exhibit sundowning, and you are doing assessment during the morning rounds, maybe falsely reassuring, you can exclude the diagnosis of delirium by doing morning assessment in patients who are exhibiting sundowning. So patient with delirium can have any level of consciousness. It can be normal, can be hyper alert, which is called as vigilant state, or hyper arousal can be there. Patient can be lethargic, that is drowsy with but non-arousable. Patient can be having stupor, drowsy. Patient is difficult to arouse, that's called as stupor, or patient is unarousable, that's coma. So there can be various levels of consciousness in a patient. Acute onset, fluctuating course, inattention with either incoherence or any altered level of consciousness. Incoherence can be patient is either easily distractible, there is disorganized thinking. For a patient who has a relatively normal level of consciousness, who is alert, you ask something, he is alert, but there is inattention. How does we define inattention? There are two things. One is patient is easily distractible, or patient have difficulty keeping track of what was being said. These are two attention deficits, and it is a hallmark. It is the hallmark of delirium. You can see the patient has tangential speech, fragmentary flow of ideas, or inability to follow complex commands often signifies attention problem. So there is this digit span test, which is quick and fairly sensitive. And in this task, patients are asked to repeat successively longer strings of digits, beginning with 2 digits in a row, set to the patient at 1 per second interval. Healthy adults can repeat a string of 5 to 7 before faltering, whereas a digit span of less or equal to 4 indicates that there is attention deficit, unless there has been another comorbidities like hearing or language barriers. And many patients with delirium have digit span of less or equal to 3. Can MMSE scale identify patients having delirium? Yes. Although MMSE scale provides information regarding 3 things. One is orientation, another is language, another is visuospatial skills. Orientation, language, and visuospatial skills. However, there are certain tasks that we do on mini mental states examination. One is spelling of word backward, DELROW, and there is serial subtraction of digits. It will be impaired in patients with delirium. Thus, MMSE, which identifies orientation, language, visuospatial skills, also tasks in mini mental states examination in delirium patients will be impaired. So patients, we know that dementia is a risk factor for developing throwing the patient to delirium. So a patient has, for example, patient with Parkinson's, who is a known case of Parkinsonism, but patient, we don't know what there was dementia, but patient who has Parkinsonism now throws delirium. So you have to think that it's not simple Parkinsonism. There is something dementia associated with Parkinsonism. It could be dementia with Lewy body. It could be progressive supranuclear palsy. Patient is harboring, or it could be that conditions such as Parkinsonism, such as idiopathic Parkinsonism, but there are idiopathic Parkinson disease we don't see dementia. We see dementia in other types. For example, Alzheimer's disease, dementia with Lewy body, or progressive supranuclear palsy. There are Parkinsonism features, but in addition to that, the patient has underlying neurodegenerative dysfunction, like patient has dementia. That's why patient has gone into delirium.